In today's video, we're going over a clinical examination of slap tears, a physical therapy guide. Good day, Kevin. How are you on this fine day?
I'm doing well. It's a beautiful, cloudy, rainy Saturday morning. Although it looks like the rain may have stopped, and I think it's going to be pretty good for the rest of the weekend. So, doing well. Excited to talk about slap tears.
Ooh, slap tears. We're going over slap tears today, huh?
I think we should stick with slap tears.
Okay, let's stick with slap tears, right? Okay. So get us going, Kevin. What do we need to know about slap tears here?
Right. So, just going over the examination process. So, someone comes in with shoulder pain. If they have maybe some slap pathology that's causing some of their symptoms, they may come in with a vague shoulder pain. Sometimes they'll report mechanical symptoms. Um, if they're moving their arm around, they might report clicking, catching, something like that. We think of as mechanical symptoms, and that's usually provoked with overhead activity. They may also complain of instability. I would think if they had maybe a type 2 or type 4 slap lesion where that biceps tendon is no longer anchored, they might have some instability there. Or sometimes if another part of the capsule is involved, perhaps they have a bank heart tear or something like that. So you want to be on the lookout for instability. And if the cuff is involved, like we've talked about in a previous podcast, they may just come in with shoulder pain or weakness. Um, and just with that alone, we can't rule out a potential slap tear. So you want to get a good history from the person. Was there any mechanism of injury? Did they fall on an outstretched arm? Was there a traction type injury? Anything like that to give a little insight into what pathology they're dealing with. And I think that's going to help guide our special tests, which we'll talk about. And like any shoulder examination, we want to clear the cervical spine. We want to check for neuro symptoms. So if someone did have a fall or a significant traction type injury, we want to make sure that they didn't have any damage to the suprascapular nerve. So we want to go ahead and make sure that there's no atrophy in the posterior rotator cuff, that things look pretty good from that perspective. And then continuing with our physical exam, checking active range of motion, checking passive range of motion. These folks may have pain with external rotation in 90 degrees of abduction. There are a few special tests that replicate this position that we'll talk about. And they may have instability secondary to excessive external rotation and a tight posterior capsule. So I think, all your normal shoulder examination rules apply when looking for a slap pathology. But you want to pay particular attention to, like we talked about in a previous episode, that mechanism of injury, and just make sure you're doing a thorough job ruling out potential other causes.
That was actually beautiful, Kevin.
Thank you, Daniel. Thank you.
A couple things I had to say, or want to say. I guess I don't have to say them. So for one, I just want to double down this idea, frogs in the throat, that this is kind of difficult to diagnose. There's just vague pain in the shoulder, and that could be anything, right? It's like, oh, my shoulder hurts. What could that be? Slap tear, rotator cuff, maybe this is instability. It could be so many different things. So it's actually a little bit challenging to diagnose because there's not one specific thing you say, oh, yes, that's a slap tear, right? So we're kind of left guessing. Obviously, we have a bunch of special tests, and we'll go over those in a minute. And then you have, MRI, and then you also have arthroscopy as kind of a gold standard reference standard. But clinically, they're actually a little tough to diagnose, right? The other thing to note on differential diagnosis is that you want to rule out the cervical spine because you're looking for potentially cervical radiculopathy. I think classically, you may see like a C5 cervical radiculopathy with pain radiating to the shoulder and weakness in the deltoid, which you might think, this is maybe slap or rotator cuff related. Just make sure you rule that out. And potentially thoracic outlet syndrome. So those are kind of the big ones that pop into my mind for ruling out the cervical spine, because all that can kind of just radiate into the same region, right? The other thing that we're on the lookout for from a diagnosis perspective, differential diagnosis, is going to be instability, right? And Kevin already mentioned this, but these folks with a slap lesion, they can actually have some instability, but we might also be experiencing some anterior instability, which is common with slap pathology. But the two are kind of kind of born together depending on the athlete that you're looking at. So if you're looking at a thrower who's been throwing for years and years and has a ton of layback, chances are they have a lot of laxity anteriorly, right? They may also present with some apprehension or instability anteriorly as well. So I'll just make sure you're running through a battery of anterior instability tests as well as kind of your slap test to figure out what's going on there. And then I think Kevin already noted this because I was writing all these things on a piece of paper as he was speaking. But generally, from an exam perspective, you can try to put the athlete into that position where they had the mechanism of injury. So if it's a thrower and you feel like it's one of those peel back injuries, which we'll talk about a little bit later, but we also talk about the podcast prior. If you wanted to check that out, link in the show notes. Essentially, folks can get hurt in layback, throwing a baseball, arms in horizontal abduction, external rotation. And from that position, they have pain because that's kind of where they got hurt. Maybe it's the follow through of throwing, and that's where they have pain. You can kind of assess from that position as well. What I will say is that I've seen several folks in the gym that have slap tears and they're pathologic, and they actually tend to hurt kind of end range flexion. I don't know why, but that's what I see a lot. So if you put them in that position, you might kind of see they have some pain. And that's a total anecdote. So I have no research to back that up, but that just tends to be what I see, kind of pain at end range there. So yeah. What do you think? Am I just spreading misinformation, Kevin?
Dude, we're going to cancel you. I can't believe you just said that.
I know. It's bad. To go along with today's video, I have a free evidence-based cheat sheet on slap tears. I'll get you up to date on all the literature on slap tears in under 10 minutes. We go over anatomy, prevalence, and risk factors for getting a slap tear. We go over the mechanisms of injury as well as a clinical presentation. We cover differential diagnosis as well as diagnosis. What are the best treatments for slap tears? Is surgery effective for a slap tear? And is physical therapy better than surgery for slap tears? Lastly, what are the return to sport rates for slap tears, both conservatively, so with physical therapy, versus getting a surgery, so either getting a biceps tenodesis or slap repair? It's a 5-page PDF. It's 100% free. I'll leave a link in the description. Go ahead and click on that and download it and get back to this video.
All right. Well, I thought this quote was worth putting in. This is from an article that we're going to talk about looking at special tests for slap tears by Chad Cook and colleagues. So the quote is, in addition, others have suggested that the diagnosis is difficult because there are no unique clinical findings associated with slap lesions and because the condition is frequently associated with concomitant shoulder injuries such as degenerative joint disease or probably arthritis, impingement, rotator cuff tears, and other soft tissue related injuries. So I think this speaks to something we've talked about, especially in the prior podcast, link in the show notes, that a lot of times with these slap tears, there are a lot of other things going on. So when we have a test that's trying to isolate a slap tear, that's going to be very challenging because we're probably going to get a lot of false positives or false negatives, false positives in these types of situations because a lot of other things could be at play. So this was just a quote that I think would be nice to keep in mind when you're getting certain results on special tests for slap tears, just understanding that there could be a lot of other things going on in the shoulder.
Yeah, I think that's confusing a little bit, probably more so to new grads and early career professionals, because we kind of want to have a diagnosis for the patient, right? Because that'll kind of help guide our treatment, or maybe we feel like we need that. But I oftentimes don't think you do, right? So if someone has a slap lesion and maybe they present with some instability, just treat what you find. Like what's limited, what's painful, what do we need to improve upon, right? So despite there being this kind of nebulous diagnosis, I think you simply treat what you end up finding in your clinical examination. All right.
Yeah. So this is the study that I was just referencing that we're going to dive into a little bit. So it appeared in the Journal of Shoulder and Elbow Surgery in 2012. And it's the diagnostic accuracy of 5 orthopedic clinical tests for the diagnosis of slap lesions. And the lead author on this was Chad Cook.
Good old Chad.
I think he puts out a lot of good stuff. I like Chad Cook, especially when he's talking about the mechanisms of manual therapy. So good. People should check that stuff out. But
I'm a Chad Cook fan too. I like Chad.
Yep. And all the Duke students we get at Champion are so good too. So
yeah,
great.
Duke's got a really good, really good teachers there.
Oh my
Oh
God.
God,
Yeah,
can't remember
they're
that. Professors. That was what a word I was looking for. Yeah, my brain is
I know
gone. I should have had
they're
my sardines this morning.
oh, dude. Gotta
Yeah,
get those
Mike
omegas
Ryman
in.
too.
Yeah, their
Solid.
staff is loaded.
Their
Great
staff
program.
loaded. That's another good word that I forgot. Yeah. Maybe I
All
should
right,
edit this
so
out. Go ahead, man.
I like it. All right, so in terms of the paper, the objective with this paper was to determine if any SLAP special test is accurate at the diagnosis compared to the gold standard, which for them was arthroscopy. So the study design was a prospective, case-based, case-control design. So essentially, what that means is that these patients were going into a clinic. They had to consent to a full evaluation and understand that they may undergo an arthroscopic surgery. That word kills me. Anyway, so they all gave their consent with that, and there were 87 participants who underwent a full exam in addition to 5 special tests for slap tears. These included the O'Brien's compression test, the biceps load 2 test, the dynamic labral share test, the speeds test, and the labral tension test. If the physician who was performing the exam and the special tests felt that it warranted an MRI, they proceeded to do an MRI. And then from that, they also said, okay, how many of these folks are good candidates for surgery? So it's not like they were just signing up for a surgery. They had to go through all this criteria, and the physician had to determine, is this someone who is a candidate for surgery? And then they would go in and they would do the arthroscopic surgery, and they were trying to compare how many of these folks in surgery are actually presenting with a type of slap tear versus what we predicted based on our special testing. So trying to get some accuracy for that.
Nice. Looks like it's going to be a good study. We'll see the
Pretty
results
good
in a second.
design. Yep.
I just wanted to say that I did a video. I think it should be up next week. So it should be up by the time this podcast is released as well. Link in the show notes. And essentially, I went over all of these special tests for anterior instability. I put sensitivities and specificities, not from this paper, but from a more recent paper in 2023 that I'm also going to talk about as well. So if you forget the test, if you want to see them again, you'll have access to that so you can check it out.
After they went through all that clinical procedure, there were 55 participants who had slap tears confirmed from the arthroscopy. So the frequency, just when they were diving into this to figure out a little additional information, we talk about in PT, we probably see type 2 slap tears most frequently. So in this study, 24 of the 55 had a type 1 slap tear, 27 had a type 2 slap tear, 0 had type 3, and 4 had a type 4 slap tear. So the results that the authors talked about was that none of the 5 standalone tests or a combo, so when adding the tests together in this study, accurately predicted slap tears during surgery. The tests, they showed minimal to no diagnostic value for a slap lesion. Only when all 5 of the tests were clustered together and they were negative, it appeared to be okay at ruling out a slap tear. And then, like we've spoken about many times now, concomitant pathology is so common. So 56% of patients diagnosed with a slap tear, they also had other shoulder pathology. So I think that's something that's, again, common that we're going to keep seeing over and over. It's important to keep in mind. And then there was one other thing I wanted to add to this is that in the conclusion section, they just had mentioned that there's probably a lot of reasons for this that they tried to note. The patient population was pretty varying. There was a lot of different variants in the patient population. And then the same physicians that were doing all the tests, they were also the physicians that were doing the surgery. So there was no blinding or anything like that.
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks, because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is, if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place, so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you, and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door, so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. And now back to your learning.
All right, Dan, what do you think about that study?
Obviously a little sad, right?
Yeah.
Yeah. And this study and the other one I'm going to talk about in a second, it seems like there's a decent specificity of some of these tests, but the sensitivity is just really, really low. One of the things I wonder is that if there's so much concomitant pathology, I wonder if the sensitivities and specificities are so bad just because there's multiple things going on within the shoulder, right? And it's hard to just zero in on just that slap lesion. If you're getting a bunch of positive slap tests and all that's doing is picking up on concomitant pathology and not the actual slap, like the sensitivities are going to be terrible, right? Because it's basically showing a bunch of positive tests when there's really no slap injury, but there's actually a rotator cuff injury that's, existing with it. So I don't know. We'll talk about how to maybe make these tests a little bit more sensitive and specific, but I think in general, just kind of sad, right? Because it's like, oh, we got all these tests for slap injuries and, they're maybe not as good as we once thought, right? And the other thing that is a little confusing, if you start reading through other studies for labral pathology in general, but particularly slap, is that some studies come out and they show an amazing sensitivity and specificity. And then like a couple years later, another study comes out and it shows horrible sensitivities and specificities. So it's even more confusing. And obviously we want to see better systematic reviews and meta-analyses that are going to lump together more of patient population. But the problem with that is that you're lumping together too many populations, right? And the next study we're going to talk about, they actually found different sensitivities and specificities for athletes versus non-athletes. And we spoke about this in the last podcast, but essentially your mechanisms of injury are very different from population to population. So you're probably going to expect a special test designed for one mechanism of injury to have a good sensitivity and specificity, but a terrible sensitivity and specificity for a different mechanism of injury. So, I think take these numbers with a grain of salt. I would love to see more research in the future that looks at mechanism specific special tests and then see if it actually truly has a poor sensitivity and specificity, right? But I don't know of any, particular studies that did this. If anything, they're just lumping everything together. And that makes Mike Reinold mad because he's like, well, it just shows these tests are not good. But really, of course, it's not going to be good, right? You got all this concomitant pathology, different populations, different mechanisms of injury. Of course, that's what you're going to see. Well, this is a study I was noting about. It's called Physical Examination Maneuvers for SLAP Lesions, a systematic review and meta-analysis of individual and combination of maneuvers from Dean et al. This was American Journal of Sports Medicine 2023. So good journal and up to date. And I thought it was a decent study to look at. There was a little more recent to see if things have changed, right, since that Cook article. They included 18 studies, and the reference standard was arthroscopy, which I think is good because that's pretty much the gold standard. You're seeing that SLAP lesion there. MRIs aren't always the best. And a lot of prior studies, and you see this as well in the rotator cuff, they'll use MRI as a gold standard when it probably isn't. But arthroscopy is considered to be that gold standard. So they use that as the reference standard. And what was interesting about this study is they looked at all of these tests in series as well as in parallel. So basically having tests in series means that, let's say you have 3 tests. And if they're all positive, then there's a particular sensitivity and specificity for that. And then tests in parallel, you only need one of those tests to be positive in a battery, right? Let's say you have 3 special tests for a SLAP tear, and just one of those is positive. You have a certain sensitivity and specificity for that, right? And similar to what Kevin was speaking about earlier, the sensitivities and specificities weren't great. I think a major takeaway is that the specificities were much better than the sensitivities. So kind of to Chad Cook's points, kind of like, well, these are all bad, but particularly bad with the sensitivities. Like some of the sensitivities are like down to 10%, right? It's like really, really bad, But using the tests in series and tests in parallel, the sensitivities and specificities went up quite a bit, right? To the point where if you had 3 tests in series or in parallel that were positive, or at least you had one of those, like the sensitivities and specificities are in the 80s to 90s. And unfortunately, this is not an open access article. So I wish I could just show you all the information, but I know that we can't. But what I will say is that the most sensitive combination of tests were the O'Brien and Crank test combo. And then the sensitivity in series and parallel, I think in series was 77%. The most specific test was Jurgensen and anterior slide test combo. And then that test in parallel was 97.8%. So at least in this study, which included a lot of other studies, obviously, right? When you start to put these tests together, we can get some better sensitivities and specificities, despite, like we said previously, different populations, different mechanisms of injury, different ages. All of these are going to mess up your sensitivities and specificities. But if we start combining them, we start to get some better numbers there from a sensitivity and specificity standpoint. What are your thoughts there, Kevin?
Yeah, I think it just speaks to like something that I think I hear you talk about a lot is that some study will come out that shows something interesting, but let's wait to see it replicated, or let's wait for future studies. And I think I've definitely been guilty of finding a study that says something really interesting, and then I just reference that study. But there's a lot of other ones out there that could show some different findings. And I think when a study comes out that seems interesting or seems exciting, we have to wait for it to be replicated, because one study, we can't hang our hat on that. So I think this study that you just went over, yeah, it does give a little more confidence in some of our special tests, perhaps, than the previous study that I had talked about. And I think we'll summarize all of this in kind of a proposed way from Kevin Wilk and Mike Reinold about thinking about the mechanism when selecting your special tests. But I think, like you said, there's definitely more research that needs to be done. And when we find a paper with certain findings, let's wait and see how it pans out. If it's replicated in the future, if there's more studies talking about special tests, then, we can kind of piece together all those studies and take the best parts of all of them, rather than looking at just the study I had looked at that a lot of people would look at and say special tests are dumb and we shouldn't do them anymore, and they're not special.
Yeah, that's true. It's like that old saying, like, fool me once, shame on you. Fool me twice, shame on me. I think it was the Thessaly's test when I was in school, like over a decade ago, that I learned. And I was like, oh, dang, Thessaly's test, like 90+% sensitivity and specificity for meniscal lesions of the knee. I was like, great. And then I got out of school and I was like 1 or 2 years in. And I remember like the newest edition of JOSPT came out and they're like, oh, Thessaly's test, new sensitivities and specificities. And it was like 10% sensitivity and specificity. I'm like, what the heck? This doesn't make any sense whatsoever. And I'm like, do I even do this test anymore? You got to throw that in the garbage. And I think it was the O'Brien's test as well. It came out at first. It's like tremendous sensitivity and specificity. And then afterwards, like not so much. So gotta basically see that with a grain of salt. Like there's a few newer tests for instability with great sensitivities and specificity. But in my mind, I'm like, I don't even know if I want to use this test because there's a good chance that, small sample sizes, so on and so forth. And not to get too far off track, but as physical therapists, I think we often hang our hat on these studies that have like 20, 30, 40 participants, and during COVID times when they're releasing vaccines, not to get too controversial, essentially they're having studies come out in young kids, right? And, I have a young kid at home, so I'm just interested in reading the research. And there'd be a study came out with several thousand participants. My wife's like, ooh, that's a little underpowered. I'm like, several thousand, that's great. You never see that in physical therapy. But it's a good point. You need a lot of people in order to have like a good study. And we're sometimes making decisions on these studies that have, very few participants. So, yeah. All right, let's move on. I'll let you talk a little bit here, Kevin.
All right. Yeah. So just talking about a possible solution, because we were talking with Mike about this in the clinic in the last week or so. And then I went back and was reading his blog and then found this article that he had written with Kevin Wilk about slap tears, and kind of their proposed solution to a problem like this is, and as you said, there aren't studies that have actually studied this to look at the sensitivity and specificity of some of these tests or the positive predictive value and so forth. In a clinical setting, but I do think it makes sense intuitively, and it's probably something that we could start thinking about with our special tests. So rather than just throw a bunch of slap special tests at everybody, have a few that you use based on the mechanism of injury. So if you have a pitcher, so someone coming in with a potential peel back injury, again, that's that horizontal abduction at 90 degrees and then end range external rotation. Maybe with that type of person, we're doing a pronated biceps load test. So that's your regular biceps load. And then you pronate the person just to put the biceps on a little more stretch. A resisted supination external rotation test and a regular biceps load test. So in all of these, you're replicating that peel back mechanism. And if it's a sensitized area for the patient, maybe these are going to be something that you could say, all right, all three of these are sensitized where we're stressing the long head of the biceps and we're replicating their symptoms. Maybe they do have a slap tear. Again, should be studied, but interesting way to think about it. Versus a compression type injury. Maybe you're testing the active compression test, the O'Brien's test, a compression rotation test, and a clunk test. Again, all of these are compressing the joint, not something you'll see an overhead athlete dealing with necessarily. So not the best test for an overhead athlete, maybe for someone who fell on their shoulder. Versus finally a traction type injury. Maybe we're considering a speeds test or a dynamic speeds test and an active compression O'Brien's test. So if we pair our special tests based on the mechanism, maybe that's a better solution. And maybe then we have a little better sensitivity and specificity for these tests than throwing everything at every person, independent of the mechanism of injury. So I thought this was a useful way to think, probably a useful way to think for a lot of other types of special tests too. We could extrapolate the shoulder stuff to other things and, potentially apply it to other types of special testing. So I think a good way to think from Mike and Kevin Wilk.
I agree a lot. And just to expand a little bit on our prior conversation, we are thinking about these poor sensitivities and specificities. I like to think about like the O'Brien's test, right? O'Brien's test, you're basically doing a loaded Hawkins Kennedy, right? So you're going into like a very classic, subacromial pain test, and then you're loading it, and you're loading the posterior cuff too, and the superior cuff, So you're almost certainly going to pick up some pathology of the rotator cuff. The other piece, and there's been some published research about this, is you're probably picking up posterior inferior instability with this test because you're going to that same exact place. So if you think about kind of this mechanism of injury based style of picking special tests, a lot of these mechanism of injuries are also provocative of other structures too. So you can kind of see that this might not be the best special test for that reason. And the other thing I just want to note upon is that if you're working with folks that potentially have slap pathology and they're more weightlifters, right? Or people that just like kind of strength and fitness, then you can still kind of pick tests based on the way they get hurt, right? If people have pain in the bottom of a bench press, bottom of the dip, you could potentially try something like a speeds test. There's different speeds variations. So essentially, I'll have a video on this. We'll put a link in the show notes where we go over all the slap tests, but you can do a speeds test with your arm straight out in front, palm up, or you can do a speeds test where it's a dynamic version, although it's not the dynamic speed. You have your hand to your side, palm up, arm straight, and you just resist flexion on the way up, which is just essentially the same thing as like a bench press or a dip, right? So I think you can kind of choose those. If you have an athlete that has more pain with, let's say, pull-ups, the bottom part of a pull-up, then maybe something like a biceps load is better because you're overhead-ish, 120 degrees, plus now you're resisting flexion, trying to tug on that labrum. So you can kind of choose the best special test for the individual. And like we said, like I don't have any research showing that this can be more effective for this population. I don't think that research actually exists. But if you're concerned that the slap tests aren't quite as good, maybe this is a way to improve the sensitivity and specificity. Like Kevin said, maybe we shouldn't throw the baby out with the bathwater and just say that these tests are all terrible. Maybe they just need to be applied in a little bit better way. And we just don't have the research yet to show that. But again, no research doesn't mean that this is actually something theoretically that works out either, right? We could be wrong. We could be super wrong. But that's just kind of what happens. We experiment and then we test it and then, we see if we're actually right or not.
Yeah, Dan, I think you made some good points there. One thing I just wanted to say is if we take a step back and think about why are we doing these special tests, right? Someone comes in, we're trying to figure out potentially what structures are involved. We know in the shoulder that there's a lot of pathology that could be present at the same time. So I would say for me, I'm thinking about these as when I see someone come in, is this someone I have to refer to a surgeon, or is this someone I can just look at their symptoms, find out what's sensitized, and treat them in the clinic? And whether I'm 100% confident they have a slap tear or a rotator cuff tendinopathy plus a slap tear or something else going on, subacromial shoulder pain, I'm not going to treat them very differently. I know we talked about this a little bit, but this information, you don't have to go crazy trying to figure out, is this a slap and what else is involved? I mean, that's good to know. And I think the more we know, the better. But at the end of the day, we're treating the patient in front of us and based on how they're presenting. So I think I'll use these special tests as a way to figure out how sensitized someone's shoulder is in certain positions, understand that these are positions we might avoid for a small period of time, maybe educate the patient that, hey, you have pain throwing. We're doing the same motion on the table that's really, really painful right now. Maybe this is something we retest as your rehab progresses and see if it starts to feel better. And if you are feeling a little bit better in this position and other things are improving, your strength, your range of motion, maybe we start introducing throwing again. So we'll talk about treatment eventually, but I think these special tests, it's not making or breaking your treatment, but it's just more information you can gather. And personally too, I think with my patients, if I think they have a slap tear, if they're not asking me what I think is happening, I'm not going to tell them, well, hey, you tested positive on these 3 tests. I think you have a slap tear in your shoulder. Because people don't know what to make of that. I think a lot of times we take for granted how much we know, and we know it's not that big a deal for a lot of people if they're not presenting like they need to see a surgeon. So I think that's just a little bit of that's stuff I want people to think about when going through these tests is just still be careful about how you're interpreting it to the patient, and just know that it's, in most cases with a slap tear, it's probably not going to change our treatment so much. We're still going to do all our normal treatment, and maybe we can come back and look at the tests over time and see if they're improving or not.
Yeah, that's great. The other day, I had a slap patient come in, and I actually didn't know what type of labral injury they had because they had been to the doctor, and the doctor told them they had a labral injury. I thought it was a slap test, and I was just going over all the literature on different types of instability special tests, right? So in my mind, I was like, I'm going to try to figure out what's going on. And I did way too many special tests. At the end of the day, I was like, I'm just aggravating this guy's shoulder for no reason. And the treatment's not going to change that much. So to your point, you don't have to go crazy. We don't even know exactly what's going on, especially if there's no instability there, right? Choose a couple tests. And if you can't necessarily differentiate between rotator cuff related pain and or slap pathology, as long as there's no medical red flags, just start treating it, right? You don't have to worry too much about that exact diagnosis. So now you guys have a really good idea of clinical examination of the shoulder for slap tears. You still probably need to know how to do all the specific slap tests. Well, I've got a video for you. It's going to be living over Kevin Coughlin's head. If you go ahead and click on that, I'll teach you how to do all the special tests to diagnose slap tears. So go ahead and click on that, and I will see you there. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I add to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.